This presentation is related to prolonged duration of vascular access for hemodialysis in North Macedonia. More than 1,500 patients are going on hemodialysis this year in Macedonia, according to our register. And all these patients going on hemodialysis need good vascular access. Patients started going on hemodialysis program using femoral, jugular, subclavian vein routes for cannulation procedures and for establishing catheters, and these vascular accesses are prone to stenosis, even for thrombosis. The aim of our study was to present our experience in creation vascular accesses modalities for hemodialysis as procedures related to prolonged duration with less complications in clinical practice. All we know that vascular access is the Achilles heel for the patients going on hemodialysis. During the period of 20 years, we performed thousands of all modalities and types of vascular access, AV fistula, tunnel catheters, femoral catheters, jugular and subclavian vein cannulation procedures. We want to know that 83% of our patients are going on hemodialysis with AV fistula and 17% of permanent vascular access due to tunnel catheters. We have reduction of the number of AV fistula during the period of COVID pandemic. We start the program of hemodialysis for our patients cannulating femoral vein, and in the last 10 years we reduced the number of patients going on hemodialysis with subclavian vein cannulation and increased the number of jugular vein catheters. We insist on femoral catheters because we need better options for creating AV fistula to the patients on their arms. Here the results we want to present about the prolonged duration of lasting of vascular accesses to our patients. They usually have exhausted blood vessels, so sometimes we have to cannulate femoral artery because we use this vascular access to bridge the time between exhausted blood vessels to CAPD, for example, or cannulating vein azygos and translumbar cannulation of vena cava inferior when the other possibilities are limited. We use also this artery cannulation for preparing the patients through all the procedures needed to point the best other options for like necklace AV graft, saphenofemoral AV graft in some limited number of patients. And here is why we use, for example, artery cannulation, because we can see that vein femoralis and vein iliaca interna are stenotic, and we do not have another options like in the middle of the picture. There are complications due to stenosis of vena cava superior, and that is fortunate. That is something that is occur like enlargement of vena azygos due to stenotic events in vena cava superior and inferior. And we intentionally use, in some cases, this vein azygos, in one case for temporary vascular access, and in 3 cases for prolonged use for permanent tunnel catheter. And in these cases, this vascular access lasting 3 to 4 years. On the right side, there is a complication in a patient going 10 years on hemodialysis with all type of vascular access, and in the last months before we tried to solve the problem, there is a stenotic events in cava superior and also enlargement of vena cava azygos. And we use this vascular access for 1 month, preparing the patient for open cardiovascular surgery procedure. And that is the case for bypass from brachiocephalic vein was changed with graft, and that was 2 Tessio catheters in this graft, and this patient lived with this vascular access another 4 years before died during the pandemic. Here we present the placement of permanent translumbar catheter and performing the hemodialysis session in the same patient. These are very promising procedure, that is aneurysmography, that prolong the duration of the vascular access to our patient, moving the all aneurysmatic masses that prone to complications like enlargement, bleeding, Still syndrome, stenotic events, thrombosis, and limiting the using of this AV fistula, and moving the aneurysm allow the patient to prolong their best vascular access. It means AV fistula. In our patients, we have bleeding, hematoma, infection, dermal necrosis out of 30 patients, and we have to use temporary catheterization for to prolong the dialysis sessions to these patients, but only 1 to 2 hemodialysis sessions, and 26 patients going after the operation procedure. Next day they go to hemodialysis using their own AV fistula. In conclusion, due to the complications after conventional use access for hemodialysis, we have performed arteria femoralis cannulation, vena azygos cannulation, saphenofemoral AV fistulas, translumbar cannulation of vena cava inferior, bypass from brachiocephalic vein to right atrium with graft disc catheter insertion, and aneurysmography recently, last few years, with good results. Aneurysmography may be an effective method for treating aneurysmal arteriovenous fistula, showing excellent long-term patency, no aneurysmal recurrence, and a minimal infection rate. It appears to be suitable for high-flow arteriovenous fistulas. These use modalities succeeded to prolong vascular access duration and improve hemodialysis patients' longevity and quality of life. Thus, they may be used as last life-saving procedures in chronic renal failure patients. Thank you for your attention.